I think that concludes the opening statements by members of the subcommittee. We'll now turn to our panel. A word of warning: we might have a vote and have to interrupt, but hopefully we'll get through the whole panel. Let me welcome you and also introduce each of you. Starting on my left is Dr. Jonathan Skinner, Professor of Economics at the Dartmouth Institute for Health Policy and Clinical Practice. And then we have Dr. Christine Castle, who is President and CEO of the American Board of Internal Medicine and the ABIM Foundation. Dr. John Goodman, who is President and CEO of the National Center for Policy Analysis. Dr. Bruce Sigsbee, President-elect of the American Academy of Neurology. Dennis Smith, who is Senior Research Fellow in Healthcare Reform at the Heritage Foundation. And Dr. Jerry Avorn, who's Professor of Medicine at Harvard Medical School. We have each of you, we ask you to give 5-minute opening statements, which obviously become part of the record, and then when you're done, we'll have questions from our members again. Dr. Skinner.
Thank you. Thank you, Mr. Chairman and distinguished members of the committee, for the invitation to join you today. Variations in per capita health care spending are now well recognized.
We'll have you speak, and then we'll break after you, so please continue.
Less well known is that growth in spending has also varied dramatically across the United States, as we've shown in slide 1. Had Miami Medicare spending during 1992 to 2006 been as restrained as San Francisco's, its cumulative savings would have been enough to buy a new Cadillac Escalade for every elderly person in Miami, thus solving both the problems of Medicare and the problems of the auto industry. The variation in growth rates may appear small, ranging from 5% in Miami to 2.3% in Salem, Oregon, but compounding makes a huge difference. If all U.S. regions scaled back their growth rates by just over 1 percentage point, as San Francisco already has done, the Medicare program would save more than $1 trillion by 2023. What explains higher spending? Almost all of the differences in spending across both regions and academic medical centers are due to the greater use of what we refer to as supply-sensitive services. That's the next slide. Medicare enrollees in higher spending regions are hospitalized more frequently for conditions that could be treated outside the hospital, see physicians more frequently, are referred to specialists more often, and have more physicians involved in their care. And more care isn't always better care. Patients in high-spending regions report being less satisfied. Physicians describe greater difficulty communicating with other physicians or maintaining adequate continuity. Health outcomes such as survival following a heart attack are no better or worse or sometimes worse in high-spending regions. What's going on? We believe that the lower quality care is largely because the payment system reinforces the fragmentation of care. Many medical decisions are in the gray area where judgment is required and physicians follow local norms. Income pressures on both hospitals and physicians motivate the purchase of new profitable technologies and the referral of more patients to specialists or to the hospital. To discourage these expensive treatments with little benefit, it's important to get the prices right. But it's also important to pay attention to quantities. Until the Dartmouth Atlas came along, no one knew that in Elyria, Ohio, the rate of cardiac stents, a common and expensive procedure to reduce blockage in the heart, was 3 times the rate in neighboring Cleveland and 7 times the rate in Pueblo, Colorado. On average, Medicare enrollees at the NYU hospital spend more than a month of their last 6 months in a hospital bed compared to just 15 days at the University of Rochester. The current Medicare system is like contracting with a new home builder, agreeing on the price per square foot, but letting him decide whether to build you a mansion or a cottage. What's the solution? I think a necessary first step is the formation of accountable care organizations, or ACOs. An ACO is a local network of providers that can manage the full continuum of care. It must be sufficiently large to accurately measure quality and expenditures, yet small enough to be manageable. Primary care or multi-specialty networks and integrated delivery systems are all examples of shovel-ready ACOs. Our research has shown that the formation of ACOs would require little disruption of current physician referral patterns, and that almost all physicians and hospitals could feasibly participate in such networks. My colleague, Elliot Fisher, has written about the path forward in creating these networks. I want to talk about the potential of ACOs in extracting some of that $700 billion in estimated wasteful U.S. spending on health care. The obvious sources of savings are the high-cost regions where per capita Medicare expenditures are nearly double the national average. One could cap payments for a small number of outlier hospitals with off-the-charts expenditures, or cut reimbursements for high-cost providers who don't participate in ACOs. I expect few hospitals will find these restrictions binding, since there are so many avenues for high-cost hospitals to scale back spending and thus avoid penalties. Another approach is to restrain the growth rate in spending. Elsewhere, we have described a plan to share savings with ACOs able to ratchet back growth in healthcare costs. This approach it encourages cost-saving technology and discourages investment in gray area healthcare with high profit margins and uncertain benefits. These policies have the advantage of not penalizing even high-cost providers, but they do not deliver cost savings until future years. In sum, I believe that accountable care organizations are central to claiming some of that $700 billion in wasted healthcare spending. While I recognize the practical challenges, it's hard to see any other approach generating the magnitude of savings we need.
Thank you, Dr. Skinner. We have, how many votes? We have 3 votes, so probably about half an hour. 5? 5, okay then. We're talking probably at least 45 minutes, maybe even an hour. Maybe even an hour. But obviously we need you to stay here. So we'll reconvene after the 5 votes. The subcommittee stands in recess.
That table was stunning about those regions.